Okay, good morning, class. Welcome to our pharmacology unit. We shall be starting our course unit starting with introduction to pharmacodynamics. So, by the end of this course unit, you should be able to define the basic concepts and terms related to pharmacodynamics, such as drug receptor interactions, those response relationships, efficacy, potency, and the therapeutic index. Also, you should be able to explain the mechanisms of action and the clinical effects of the different classes of drugs, such as what we call as agonist, antagonist, fatty agonist, and also the inverse agonist. To also be able to describe the factors that influence the pharmacodynamic response of drugs, such as receptor numbers and affinity, drug concentration, and duration of action, tolerance, and sensitization, and pharmacogenetics. And fourth, we should be able to apply the principles of pharmacodynamics to optimize drug therapy and to prevent or manage adverse reactions. So, what is pharmacodynamics? By definition, we said pharmacodynamics is the branch of pharmacology that investigates the drug's biochemical and physiological effects and their mechanism of action. So, basically, in pharmacodynamics, we are looking at uh, what, what is the drug made out of, what is the biochemical character of the drug, okay, and what does it do into the body, the physiological effects, and their mechanism of actions. That's why sometimes we say pharmacodynamics is just all about looking at what does the drug do to our body, okay, and the reverse is true when we talk about the pharmacokinetics, where we are trying to see what does the body do to the drug. So uh, it explores how drugs bind to receptors, to enzymes, and other molecular targets in the body to produce the therapeutic or the adverse effects. So basically, what happens is that drugs are chemical components that binds to enzyme or cellular receptors within our bodies. And when this one happens, we get the results. The results is either the drug will produce the therapeutic purpose that we need, but also sometimes it doesn't end there. The drug also sometimes ends up causing what we call the adverse reaction. That's why always drugs have adverse reactions. But no matter what, our aim is to get the benefit from the drug, which is the therapeutic benefit. Let's look at the drug receptor interactions. Drugs exert their effects by interacting with specific receptors in the body. Receptors are proteins on the surface or within cells that recognize and bind to particular drug or endogenous substance. When a drug binds to its receptor, it can either activate or inhibit a biological response, depending on the nature of the drug and the receptor. So what happens is once we take a drug, these drugs always have specific uh, parts, receptors that they bind to. Okay, it is selectively binding to other receptors and not just to the others, simply because that specifies the specific action of this particular drug. Okay, just the same way in the log and here hypothesis that we saw in the mechanism of action of enzymes in our previous biological or chemistry classes. So what happens is for every drug, if this is a drug molecule, there is always a receptor that is set in such a way that it has a ligand that is modified to fit the drug, the site of entry. So it is like the lock is like the key and lock hypothesis where the receptor is the lock and then the drug is actually the key. So the drug enters to the active binding sites in the receptor, and then the receptors produces the desired effect. And this effect could be the therapeutic effect, but also sometimes we have some adverse effect in regards to that. Okay. So this figure here demonstrates the binding process, but of course we know that the drug acts in many ways. Others feed the receptors, others are just like blocking agents, as we shall see in the coming slides about agonists, antagonists, and how they interact with the receptors. So let's look at types of drug receptors. Number one is the ligand-gated ion channels. Number two is the G protein cofold receptors, GPCRS. The ligand-gated ion channels, these receptors regulate the flow of ions across cell membrane when activated by specific ligands such as the neurotransmitters or drugs. For the GPCRS, these ones are involved in numerous physiological processes and are the targets of many drugs. They transmit signals inside the cell when activated by a ligand binding. Number three, we have the enzyme-linked receptors. These receptors activate an enzymatic domain upon ligand binding by initiating intracellular signaling cascades. So what happens is in the enzyme link receptors, once the enzyme is linked with receptor, then a series of intracellular signal cascades begin, okay, upon binding of the ligand. You see a lot of biochemical reactions occur and we start to see the outcomes. Nuclear receptors are receptors located in the nucleus and they regulate the gene expression upon ligand binding. Let's look at the agonists and the antagonists. What are agonists? We said agonists are drugs that bind to receptors and activate them, leading to biological response. They mimic the action of endogenous substance. So with agonists, it is just like it supports, okay? It supports the action, okay? It binds the receptors and activate them, okay? Antagonists are drugs that bind receptors but do not activate them. Actually, they deactivate them. So it's antagonized, it's opposing the action, okay? Instead, they block the binding of endogenous substance or other drugs and then preventing the action. Let's look at this picture at least to help us make more sense of what we are talking about between the agonist and the antagonist. So we said agonists are drugs that occupy receptors and activate them, while antagonists are drugs that occupy receptors but do not activate them, and antagonists block the receptor activation by the agonist. So if this is our agonist, okay, and then this is the binding site, okay, to the receptor, and then we shall see what happens. So it binds, and then the full axon is activated. Then we see our effects, that the desired effects that we intend to see. That is how an agonist works. At the same time, an agonist and antagonist can work together in an opposition to each other. So this one is supposed to produce the positive effect, while this one is producing a negative effect. It's opposing the action of the agonist. If these two are put together, because this one counters the action of the other, you will see that we shall have results, but it's less activation. We shall not get the expected therapeutic effect that we desired if this drug was used alone, because there is an opposing drug, if I can put it in that case, for example. Now let's look at what happens when the antagonist binds to the receptor site. Here the antagonist bind is an opposition agent, it opposes all the actions, and what happens is that we get no activation, no results. Okay, so agonists, antagonists, and when they are together, we get a minimal. There will be some activation because of the agonist, but it will be minimal. But here we have a large full activation because the agonist is in full action. Here the agonist is antagonized with the opposition antagonist, and then less action. Here it is a full action of the antagonist, and then no activation of receptors. A partial agonist. So agonists can be full agonists or partial agonists. So we are looking at what a partial agonist is. You say these ones activate the receptor, but to a lesser extent than a full agonist. They produce a weaker but sometimes more sustained effect. This can be beneficial for avoiding strong side effects associated with full agonist. For example, a drug like buprenorphine, which is a partial opioid agonist. These are pain modulators, to be honest. Uh, these are drugs are used in pain modulation, just like our tramadol. These are opioid derivatives, and we use them in the management of pain. It's used to treat opioid dependence as it provides pain relief without intense euphoria and addiction. So actually also in addition to pain, also there is the issue of dependence, because all the opioid derivatives has one of the major side effects or reverse effect with them is the issue of dependency. And we should always be careful. That's why we are prescribing the opioid derivatives like morphine, diamorphine, and even tramadol. We are not supposed to give longer dosages to the patient, otherwise this person will become drug dependent, and withdrawal will become a problem. So yeah, it relieves the pain without the intense euphoria and addiction potential full agonists like morphine. Types of antagonists. We said physical antagonists are the drugs that physically interfere with the access of the agonist to the receptors, such as charcoal, oscillating agents, or radioligands. Okay, so they are just physical antagonists. Chemical antagonists are drugs that chemically react with the agonist and form an inactive product such as tannins, oxidizing agents, or the nitrics. Physiological antagonists are drugs that act on different receptors or pathways but produce opposite effects on the same physiological functions, such as histamine or adrenaline, glucagon, and even insulin. Hydrochlorothiazide or trimethoprim. Hydrochlorothiazide is just one of the diuretics, which is a thiazide diuretic that we use. You might have known Lasix commonly, so we use all of them, especially in patients with renal failure, because um, they allow these particular patients to be able to pass some enormous amount of urine because of their actions in the renal tubules. Um, Still with the types of antagonists, say receptor antagonists are drugs that bind to the same receptor sites as the agonist but do not activate it. They can be further divided into the competitive antagonist and then the non-competitive antagonist. So the competitive antagonists compete with the agonists for the same binding site. So they compete for the same binding site and can be overcome by increasing the concentration of the agonists, such as atropine, naloxone, or propranolol. Non-competitive antagonists bind to a different site on the receptor or irreversibly to the same site and cannot be overcome by increasing the concentration of the agonist, such as phenoxybenzamine, ketamine, and clozapine. Ketamine, as we know, is one of the anesthetic agents that we use during anesthesia, during surgical procedures, so that we induce the anesthetic effect before we can be able to proceed with the operation processes. Let's look at the time response curve. We say the time response curve, also known as the drug concentration time profile, is a graphical representation of the relationship between the concentration of the drug in the body and the time after it is administered. So what is so important about the time response curve? This one gives us a measure of how much amount of the drug uh, is within the body system, and how long is this one sustained before the drug levels are removed by the body system, and how long does that take? Gives us almost also the measure of really the half life and the duration that we expect the body is benefiting from the therapeutic effect of this particular drug before it is eliminated in the body, maybe by the liver or through the kidneys, before it is detoxified, before it becomes chemically less active. So all these measures gives us a collective understanding of how best does the drug work, but for how long, for what duration, but also what effect does it, what is the desired effect, and what is the desired therapeutic range that this drug will produce. Okay, so this is the graph. We look at the drug concentration and then over time. Okay, so the y-axis is the concentration of the drug, and then the y-axis is the duration. And then the curve itself, from the onset up to the time it goes down, is trying to tell us that what happens if this is time zero and we are giving, for example, if this is an IV medication, we are given an injection here, and then this drug goes the concentration increases in the body, and then with time, the body is working on it, is reducing it down because it's getting eliminated. So we have the line here in the middle, and then we have the peak of the action of the drug, and then the period taken. This is the therapeutic window, for example, the desired therapeutic range. So it's between the lowest and the highest, and we look at how long does does this drug stay from the onset of the effectiveness to the time that it falls down to the effective level. So this one gives the duration of action for that particular drug. For weeks, the body is benefiting maximally from the drug, uh, achieving the desired therapeutic range. Okay. Above this level is the toxicity level. These are levels that we don't want them to be reached because already if it is here, it's telling us that the drug is already giving us more toxic effects above the desired effects that it is intended for. Okay, we have this supratherapeutic level. So this is once the therapeutic window is broken. If the action goes to that range, it is already above. If it also remains below this, it is under. That means the drug is still within the minimal standards. It's not what we expect, and it's maybe not enough to produce the action needed to treat the disease. So this is the window that we always intend every drug to be sustained at, because this is the one that will correspond to the effect we need to cure the disease or to kill the microorganism whatsoever. We look at the time response relationship. We said minimum effective concentration is failure to reach to the minimal effective concentration leads to no pharmacologic effect. I already explained this. So the MEC is trying to look at the minimum effective concentration. So if the drug does not reach that level, meaning it is like an underdose, no pharmacologic effect. The toxic threshold, when we exceed the peak level beyond the toxic threshold, we are already exposing this person to more toxic effects. So it is really a balance of not underdosing, not overdosing, but to remain within the desired therapeutic range, the therapeutic index. Optimal drug concentration is positioned in the midline of the therapeutic range for optimal efficacy. Here we are looking at the efficacy of the drug, which is measured by therapeutic window. Maximum drug response represents the peak effect or maximum drug response. Time course of drug effects, onset of action, this one refers to the time it takes for a drug to start producing a therapeutic effect after administration. So when we give the drug, it doesn't just reach that peak immediately, but it takes some time. So we measure this time from the time of administration of the drug until the time it starts to cause the action, is what we say onset of action. Duration of action is the length of a time of a drug maintains its pharmacologic effect in the body before being metabolized. So this one starts from the time of onset of action to the time that the body has metabolized, and the therapeutic window is going down because already the drug is metabolized by the liver and is already maybe getting eliminated in the kidneys. Okay. Offset of action is the time it takes for a drug's effect to diminish after discontinuation of the metabolism. Drug response relationships. We said dose response relationship. We said a dose response relationship describes how the effect of a drug varies with its dose. So a dose response curve is a graphical representation of this relationship, usually with the dose on its logarithm on the x-axis and the response or its percentage on the y-axis. So the dose response curve is a logarithmic expression. It's a logarithmic expression in such a way that uh, the x-axis is the logarithmic is the logarithm measure, while the y-axis uh, uh, is the percentage. Okay, it's measuring this percentage. So we're looking at dose response relationship. So here is the measured response from the drug And then we look at the slope of this graph, okay? Minimal and then maximum efficacy and then the potency. So if we check the slope, if we if we measure the slope, the y-axis and the x-axis, this one gives us what we call the dose response relationship of this particular drug. Efficacy is the maximal response that can be achieved by a drug, and safety is the margin between the effective and the toxic dosage of a drug. So when we talk about efficacy, we are looking at the maximum response that can be achieved by the drug. But safety is the margin between what is the effective dose needed to get the efficacy, and then what is the toxic dose. And whatsoever the case, we should be able to achieve efficacy within safety levels. Within safety levels. Potency is the relative amount of the drug required to produce a specific effect. More potent drugs have the same product at the lower dosages. We are still looking at the graded and quantile dose response relationship. So the graded dose relationships represent the continuum of response observed with increasing drug doses. So here we are looking at what happens when we increase the dose of the drug. Okay, it is graded and quantified. It allows for measuring and comparing the magnitude of reactions in individuals or experimental studies systems. Okay, so it is here again. We have the minimal dose or the threshold dose. Here we have the dose response, maximal response in terms of percentage. Okay, 0%, 10% is graded. Here we also have the same, the logarithmic drug concentration in algorithms. So we can see the logarithm increasing, okay, from 0.01 and then this one, and it goes, and again here it is the slope. Okay, this slope here gives the graded quantile dose response relationship when we calculate the slope. And the midline here, the 50% of it corresponds to the first logarithm. Okay, and in between here is the potency of the drug, which is the EC50. We shall see more about this in the next slide. And so this is the half of it, and this is the half of it. Um, Still continuing with the graded and quantile dose response relationship, we said quantile dose response relationship describes the distribution of responses in a population, and it focuses on the percentage of individuals who respond to a drug at different dose or concentrations. So let's again look at this graph. This graph extract has two things to tell us. Okay, we have the ED50, we have the LD50. I will explain more about this. And then this is the dosage of the drug. So from the lowest to the highest. So it has to tell us what happens in an individual when we continuously increase the drug dosages. What do we observe? Now let's look at percentage of individuals responding to the drug. The y-axis is talking about number of people. So this like for example what we do in the randomized controlled trials. Okay, like even in the animal studies, we first do these studies to see like how many people will respond well. What number of people respond well to the effects of this particular drug, and that becomes the basis of determining the toxic, the safety levels and also the toxic levels. Okay, so let's look at the blue, the graph in blue, for example, and the curve itself. So looking at this y-axis, percentage of people responding, and also the x-axis, the increasing amount, quantity, the dosages of our drug. And then we have this population group and also this population group. So here we have cumulative percentage exhibiting therapeutic effect. So this is the percentage of people who are exhibiting therapeutic effect. That means they are responding to the drug, and the number of people responding to the drug, they are getting the benefit of the drug without any adverse effects. Okay, so it is corresponding, the dose response is corresponding to within the normal uh, normal expectations of the treatment. The next one is a cumulative percentage dead at each particular dose. So the LD here means as a lethal dose. Lethal means dead. So it tells us that at what dosage shall we reach the killing effect, where the drug is now killing someone. That is the worst case scenario that will happen when there's an overdose. While this one is looking at the drug has worked and nothing wrong has happened to the person. Okay. So here we see it starts at a certain point and then it reaches a half and then it goes down, and exactly this is the Gaussian distribution. This is like how the normal distribution of the response curve in a population. This and this percent is requiring those to exceed desired effect. It's up to here. So here our ED50, which is the midline, is here. So we can take this measure as our wanted the important response. Okay, and then if 50% of the individuals, so the interaction of this line with this one gives us a measure of the safety dosage of this drug. While here, the midline of the fig of FIFO dying because of being exposed to increasing dosage of this drug is made around here, around between 80 and 160. I think this would be around 120 or something around there. And then when we follow this line to where it meets with D50, this gives us the level at which the toxic, if the lethal dosage of this drug, where if a person is given 50% of the people die when they are given this particular dosage of this particular drug. So this one becomes a two basis of determining uh, our safety levels within these drugs using the graded and the quantile dose response relationships. Okay, pharmacodynamic parameters. We are still continuing. This slide explains already what I've talked about in that graph. The EC50, which is the effective concentration at the 50%, is the concentration of the drug required to produce 50% of its maximal effect and is used to assess the potency of the drug. The ED50, which is called the effective dose, 50% is the drug dose required to produce therapeutic effect in 50% of the individuals. It is commonly used to determine the optimal amount for medicinal purposes. So here it gives us what is the optimal milligram, what is the optimal amount we need. Okay, it's a measure of the effective dose that we need to treat this particular disease. TD50 is the toxic dose, as we saw in the red colored graph. The dose at which the drug produces a toxic effect in 50% of the individuals in the population. It is used to evaluate the potential toxicity of the drug. So TD50, we use it to measure the potential toxicity, toxic dose. ED50 effective dose, this is the therapeutic effect, and we use it for getting the optimal amount. EC50 effective concentration is the concentration of drug required to produce 50% of its maximal effect, and we use this to measure the drug potency. So the drug potency is determined by the EC50. Therapeutic index is the ratio of the TD50 to the ED50. So exactly, already we saw it. It's just like the slope. We get the ratio of the TD50 to the ED50, and it indicates the drug safety margin with a higher value indicating a wider margin of safety. Drug-drug interactions at the receptor level. So we also have drug and the drugs interact with each other. So drug-drug interaction can occur at the receptor level when two or more drugs compete for the same receptor binding site or interact with the same signaling pathway. We saw this in the agonist and antagonist, and we saw the effect that was produced when they are competing, and the effect that was produced when the agonist is alone, and also when the antagonist is alone, and we saw the results. Okay. Additive effect is when two drugs with similar pharmacodynamics are combined. So somebody is taking the same two different drugs at the same time, and these drugs have an effect of additive effect, and then this person gets more effects than when this one drug is taken at one time. Okay, so when two drugs with similar pharmacodynamic actions are combined, their effects can be additive. resulting in increased overall response. We shall see some of the drugs that may not we may not be able we are supposed to take them at the same time because they produce an allergic effect and later on you will get like a lot of an overdose reaction response because they're working together. Synergistic effects. Synergistic means they work together and support the action of each other. In some cases, drug combinations can have synergistic effects where the combined effect is greater than the sum of the individual effects. Antagonistic effects when the two drugs have opposing actions, as we already explained previously. We look at the mechanism of drug action. While drug receptor interactions are the primary mechanism of drug action, drugs can also exert their effects through other mechanisms. We have the enzyme inhibition or induction. This is where drugs can inhibit or enhance the activity of a specific enzyme affecting biochemical pathways in the body. Modulation of ion channels. Some drugs can interact with ion channels, altering the flow of ions across the cell membranes and influencing the cellular excitability. Alternation of cellular processes. Here, drugs may affect various intracellular processes such as protein synthesis, cell signaling, or DNA replication. Interaction with the DNA or RNA. Certain drugs directly interact with nucleic acids, affecting gene expression and inhibiting viral replication. You will see more of this when we shall be talking about the pharmacokinetics and dynamics of the antiretroviral drugs, okay, like the nucleoside reverse transcriptase inhibitors. They work with interaction with DNA or RNA molecules. Factors affecting drug response, we said individual variation in the drug response can result from various factors. We have genetic factors. Genetic variations can influence drug receptor expression, metabolism, or target sensitivity. Age, sex, and body composition. Age, sex, and body weight and composition can impact drug distribution, metabolism, and response. This is true, as you will get to know that the dosages we give is age dependent. Like for example, in pediatric, it's not the same dosage in adults. This is just because of these factors. Okay, sex and even body composition. All this influences the drug response. Disease states, underlying medical conditions can alter the drug pharmacodynamics by affecting receptor expression, organ function, and also the drug clearance. So as we shall get to know, there are certain drugs that we don't give to people with renal failure, people uh, with renal failure, for example, the drug nitrofurantoin and quite many others. If we have a patient that came and we are prescribing for this patient and we know this is a renal failure patient, we need to look at which particular drugs will fit this one because others will not be cleared and will cause more accumulation of toxicity in this particular patient. So drug interactions, concurrent use of multiple drugs can lead to pharmacodynamics interactions, modifying the response and to the individual drugs. Receptor desensitization and tolerance. So receptor desensitization is prolonged exposure of an agonist drug can reduce receptor responsiveness, requiring higher dosages to achieve the same effect. So what happened here is that the receptors get desensitized because they become used to the same drug. Okay, so if this drug has been taken for long, the receptors get desensitized. This person may develop like you will not have more, you will not feel more impacts of the drug. The example is we always see this in the theater, like we are sending someone to the, we are preparing someone for the theater, and then we give the like the ketamine, of which we expect this person to be sedated already in few minutes so that we can start our theater work. But you find some people don't respond quickly because maybe all along they have been taking, some of them have been smoking and also the effect of nicotine on some of these receptors. So sometimes we even ask them, do you smoke or do you, yeah, have you ever been like using some of these illicit drugs? Because already they may not respond to this same dose like the other person. And this is where sometimes we do some dosage adjustments to get the desired effect. Tolerance is repeated drug administration can result in tolerance where the body becomes less responsive to the drug, necessitating higher dosages to produce the desired effect. Receptor upregulation, chronic exposure to an antagonist. So this is upregulation. Uh, this occurs instead when we expose to the blocking agent, the antagonist. Okay, it can cause an increase in receptor expression or sensitivity, so that even a small agonist causes a wider outcome. Okay, requiring higher drug dosages to achieve the same effect. Sensitization occurs when repeated exposure to a drug leads to an enhanced response, either through increased receptor sensitivity or altered downstream signaling pathways. The therapeutic index and septimazine. The therapeutic index measures the drug septimazine, calculated as the ratio between the toxic and the effective dosages. You can refer back to our graph that we looked at before. A more comprehensive therapeutic index indicates a more significant septimazine, meaning there's a greater separation between the therapeutic dose and then the dose that may cause toxic effects. And exactly this is what we expect from every drug. But unfortunately, it's not the case. Genetic, environmental, and individual variation in drug response. We say genetic, environmental, and physiological factors influence individual variation in drug response. Genetic factors can impact drug metabolism, receptor expression, and drug target interactions, leading to individual drug response variability. Environmental factors such as diet, lifestyle, and exposure to other substances can also affect the drug response. Physiological factors including age, sex, body composition, and underlying medical conditions can influence drug pharmacodynamics and alter individual drug responses. Drug interaction and pharmacodynamics. We say drug-drug interactions can occur at the pharmacodynamic level, affecting the magnitude and nature of drug effects. Additive interactions, when two drugs with similar pharmacodynamic effects are combined, their products may add up, resulting in increased overall response. Synergistic interactions, we already looked at this in the previous lecture, and also antagonistic interactions. Let's look at the placebo effect. What is the placebo effect? We say the placebo effect refers to the phenomenon where a person experiences a perceived improvement in symptoms or therapeutic response due to a belief or expectation that they are receiving an active treatment despite receiving an inactive substance. The placebo effect highlights the importance of psychological factors and patient expectation in influencing therapeutic outcomes and subjective responses to drugs. So once again, when we are performing the randomized control trials, especially in the drug trials, when we are trying to initiate a new treatment, normally what we do is we do a double blinded treatment where one group is exposed to the drug and one group is exposed to what we call the placebo. But this one happens in such a way that the two groups don't know themselves and they don't know who is receiving which particular drug. For example, if we need to measure the effect of sugar uh, in causing diabetes, and this is a cohort study, and we are studying maybe a group of 500 people that we are following prospectively to see what happens to them in the next 5 years, and see the groups, which group develops diabetes, which and doesn't develop diabetes. So we divided the two groups. One group, every morning we give them sugar. We give them sugar of similar amount. The other group, we give them something else, but which is not the table sugar. In such a way that they feel that they are taking sweet, something sweet, which is the same sugar, but actually it's a placebo. It's something that is not having the chemical constants of what we are giving. And in that case, these people might feel that okay, they are taking, all of them are taking sugar, but actually at the end, it is like a psychological treatment. It's like a psychological treatment. So what they're saying is that the placebo effect refers to a phenomenon where a person experiences a perceived improvement in symptoms or therapeutic response due to the belief or expectation This might be a common scenario, especially also in South Sudan, where already some people feel that they only respond, their body system respond well only to injectables, for example, to injectables. So somebody comes to the clinic and is diagnosed with malaria. This person will say oral medication will never work with me. Okay, this person, even if you give him an injection, that is mimicking maybe the artesunate, but at the same time, maybe you're giving him the treatment, the oral treatment of malaria. He will just feel that malaria is getting cured because of the artesunate. If you give him something, an injection similar to artesunate, but which is a placebo, does not have the placebo effect, this person will just feel that already you have really treated him because it's already a feeling. It's a psychological kind of feeling, and it's a psychological treatment. Certain populations may exhibit unique pharmacodynamics response to specific characteristics of physiological differences. We have pediatric populations, children have different ways, okay, different receptor expression, drug metabolism rates, they have high metabolism than adults, response patterns than adults, and require adjusted drug procedures. Geriatric is the elderly. We say age-related changes in receptor sensitivity, organ function, and drug clearance can impact drug response in older individuals. Pregnant or breastfeeding individuals, physiology changes during pregnancy, lactation can affect drug distribution, metabolism, and potential transfer for the fetus. And that's why we really need to be careful, and that's why we have specialties in all these departments. It's just because they have different pharmacokinetics and also pharmacodynamics. Adverse drug reactions are the undesired and harmful effects of drug administration. ADRS can occur due to pharmacodynamic effects such as excessive drug response, off-target effects, or hypersensitivity reaction, as you might have heard about with the penicillins or other drugs that causes hypersensitivity reactions. The adverse drug reactions can range from mild, okay, and to severe, and the occurrence may depend on individual factors such as drug characteristics and the dosing regimen. We have basically four types. We have type A, which is augmented. These are the most common and predictable adverse reactions that result from an exaggeration of the drug's normal pharmacologic action. They are usually dose dependent and can be managed by adjusting the dose. Type A augmented is normally dose dependent. Okay, so if we give the right dose for the right person, for the right weight per kilogram, normally it is a minimal thing. Examples could be sedation, bleeding, or nausea. Type B is bizarre, is the most serious one. These are rare and undetectable reverse reactions that are not related to the drug's normal pharmacologic action. They are usually not dose dependent and can be severe or life threatening. For example, is the allergic reactions, like with the penicillins, severe skin rashes, or even liver failure, or even shock. Okay. Type C is chronic types. These are reactions that occur after long-term use of a drug and are related to cumulative dose or duration of therapy, like people on chronic medications. They may not be apparent until after the drug is discontinued. Example include osteoporosis, diabetes, or someone with cataracts. Type D is the delayed adverse reactions. These occur after a long latency period following exposure to a drug. They may be related to genetic factors or immune mediated mechanisms. Examples include cancer, teratogenicity, or autoimmune diseases. Type E, we said end of treatment. These are effects that occur when a drug is withdrawn or its dose is reduced. They may be due to rebound effects, withdrawal symptoms, or loss of therapeutic effect. Example include seizures, depression, or hypertension. Like people who are already drug addicts and we want to remove them out from this, normally it's not an easy thing. They may present with all this kind of thing. That's why it's difficult to stop someone who is a drug addict just at once. Okay, even this also occurs with smokers. You cannot stop smoking in one day, otherwise you'll start to see quite a number of reactions. Okay, pharmacogenetics and pharmacodynamics. Pharmacogenetics investigates how genetic variations influence the drug response, including pharmacodynamics. Genetic polymorphisms can affect receptor expression, sensitivity, and drug metabolism, enzymes, or drug target interactions. Pharmacogenetic testing can help predict individual drug responses, optimize dosing, and minimize the risk of adverse reactions. Pharmacogenomics and personalized medicine. We said pharmacogenomics combines genetic information with drug therapy to enable personalized medicine. By considering an individual's genetic profile, healthcare providers can tailor the drug treatment to maximize efficacy and minimize adverse effects. Integrating pharmacogenomic data in clinical practice can potentially optimize drug selection, dosing and also treatment outcomes. Okay, we have come to the end of our lecture, and thank you for being with me, and we meet in the next lecture. Bye bye.